Hi, everyone. Thank you for joining us. Happy Wednesday afternoon. Hi, everybody. Thank you for being here. It's very exciting. My name's Sarah, and we're just going to give everyone 3 minutes to join. So while that's happening, if you wouldn't mind introducing yourself and just letting us know where you're joining from and what role you do in palliative care or otherwise, that would be wonderful. I can see there's Jenica. Hi, Jenica. And Julie. I can see Julie and Diana. Thank you for coming. Lara. Kate. Hi, Kate. Hi, Abby.
Hi.
Jess Brown is there. Hi, Jess. Hi, Courtney. Thank you for coming, all of you, on this lovely Wednesday afternoon. I can only say that because it is in Darwin, but I don't know if is it rainy elsewhere? It's beautiful here. We're just giving people a minute or two to join before we get started. 26 people, that's pretty cool. Hi, Penny, thank you for coming. Ingrid, we've got Renee from Wodonga, thank you, and welcome, Renee. Wendy from In Community Palliative Care. Wendy Thomas, thank you for coming, Wendy. We've got Ingrid. Hi, Ingrid. Ingrid, I reckon I see Ingrid comes to lots of these. Thanks, Ingrid. Shout out to Ingrid. Amanda. Hi, Amanda. Jess from Melbourne. There's Penny. Jenica from Eastern Palliative Care. All right, I think we get going. Thank you all of you for joining us. We've got 30, and I imagine there are going to be others that are joining us. So if you hear the little ding, that's just people joining. So my name is Sarah, and I am one of the committee members of PCNA. And so today's webinar is going to be about palliative care in disability group homes. And I'm going to talk more about that topic in a minute as an introduction, but just a few housekeeping items and also an acknowledgement of country before we get into that. So I'll just do an acknowledgement before we start. So I'd like to start by acknowledging the traditional owners that you are joining on today, and we will all be joining from different lands. And so I'm joining from in Darwin, which is the land of the Larrakia people. And I pay my respects to their elders and past and present and recognise their ongoing connection to the land, waters, and their community. I extend my respect to anyone, Aboriginal or Torres Strait Islander people that are joining us today. And we at PCNA hope that we continue to learn and walk alongside First Nations people as we provide culturally safe and compassionate palliative care. So thank you for joining us. Before we get into introductions, I just want to do a little bit of housekeeping. So if you can, please turn your camera on just so that we can see you. It makes the conversation way more engaging if we feel like we're talking to real people. And it'll turn your microphone off. What I will really encourage you to do, because this is in the prep for this, Alan and Maria and I have got together, and even in that prep conversation, I've learned so much. So this is going to be a really great opportunity to learn. So if you have questions, as we are talking, write them down or put them in the chat, or be at least thinking about what you can ask Alan and Maria, because this is an awesome opportunity to use their knowledge to learn. So that's all I have to say. So then I'll introduce Alan and Maria. So Maria, some of you may have actually listened to Maria's webinar on disability and palliative care that she did last year, and that's available on the PCNA website. So you can go back and listen to that. And so Maria has worked in New South Wales Health for 30 years, and her current role is in the Southeastern Sydney Local Health District. And her title is that she is a Neurodiversity Palliative Care Lead CNC. And she has lived experience of caring for 2 children with intellectual disability and palliative care involved in that. And she's involved in a number of different nationwide committees in terms of disability and palliative care. So wave, Wade Maria, where are you, Maria? She's going to come be pinned in a minute. Oh, there she is. Yep, very good. And then I'll introduce you to Alan. Alan has over 20 years experience working with people with a disability, and she began her career as a support worker, but she's also worked as an education inclusion worker and then a registered nurse. So Alan is currently the clinical services manager at Civic, and she leads a multidisciplinary team responsible for providing person-centered support and palliative care and care for people with disabilities. So welcome, Alan. So Alan, can you wave? There you are. Very good. So James, could you pin us so that it's not like the Brady Bunch? And then everyone, let's see, are you pinning it? Are we big and everyone else small? On my screen, we're all very small.
So you're in the middle.
Can
you're in the middle, and
good.
there's little ones across the top.
Sorry. Okay, great. As long as it's free for everyone else, that's fine.
It will follow the speakers. So on the recording, the three of you are pinned.
Cool.
But as you speak, it should pop up for everyone else.
All right, thanks, James. That's James, by the way, everyone. Like the brains and the motor of PCNA. All right. So this topic, we are talking about palliative care in group homes. Now, this topic is something that I have. I don't feel like I have much knowledge on, and certainly in my experience as a community palliative care nurse, there's just almost the problem of getting good palliative care into group homes almost felt insurmountable. So this webinar I'm very excited about. So we're going to start with a question to Alan, like a very pragmatic, factual question, really. So Alan, can you tell us what is a group home? And we're going to say in Victoria, we call them SRSs, but what is a group home? Who's eligible to live in one? And who works in them?
Okay. Hi, everybody, and thank you all for joining to listen to me do an awful lot of speaking, I think. So first of all, group homes are homes that people live in with disability generally. So that can range from psychosocial disability, physical disability, intellectual disability. The spectrum is large. So, there are different terminologies for these. In the area that I work, we refer to them as SILS, which is the NDIS terminology. So that stands for Supported Independent Living. And there are a range of different acronyms for all of these things. So for the purpose of this conversation, we'll just stick with the group home terminology because I think that covers all states and everybody's going to know what we're talking about. So where I work, so Civic, we have an array of group homes. We have about 50 of them spanning from the south coast of New South Wales up to the city, Sydney being the city that I'm talking about, and then out towards the Blue Mountains. So we have a range of different people that live in them. Ideally, we don't have more than 4. Sometimes there are 5, but 4 people in each group home. And the staffing will be funded by the ratios that is deemed appropriate by the NDIS. So as much as it doesn't sound like that is very person-centered, it is in one respect, because each individual that lives in their house will have a range of plans and services that are designed specifically for them. And then out of those services, they will work out a ratio of care. So for example, somebody might need physical assistance in the morning with their personal care. So they may need 2 people to assist with washing, dressing, showering, hoisting, whatever it might be, but they only need 2 people for a short period of time in the morning. And then the rest of the time they have a power chair and they are self-sufficient throughout the rest of the day. So the funding for that person will mean that they have 2-to-1 supports in the morning and then maybe 1 to 3 later on in the day, where they can be 1 of 3 people and 1 staff member. Somebody else in the home might require 2-to-1 assistance later on in the day, and the other person might need 2-to-1 in the middle of the day. So it all needs to be worked out in terms of ratios. So when we are looking at somebody whose health requirements have changed and therefore the support requirements have changed, we need to look at the ratios that they have in the group home. So they are not run like aged care facilities where they have staffing 24/7, no matter who is in or out. They are staffed according to the individual requirements of the people living in the homes. Does that
Yes,
answer that question?
no, it does. So I guess there's two things from there that amaze me. One that really amazes me is that there's not a set like staffing ratio for a group home. That's in itself is pretty amazing. I guess my follow-up question, Alan, is generally who is it? Is this too vague a question? Who works there? Like, is it generally carers, people who have done a certificate or they've done a diploma or?
So there is no minimum requirement, unfortunately. And you know, we can dive into the whole registered versus non-registered parts of the NDIS. So for a long time that there were group homes that were unregistered, and now they're kind of fixing that. So they really didn't have very many guidelines as to who could be in there. So at Civic, we made sure that people have a minimum of a certain disability, individual support, aged care, whichever one is most relevant. But it is not necessarily enforced across the board. So you are talking about support workers that may not have anything other than a Cert 3.
And how long does Cert 3 take to do? Like, are we talking like a couple of weeks or a month, or do we know?
I don't know the answer to that, actually.
Okay.
I've never done the
It's around 6 months.
Thank
6
you.
months. All right.
Yeah.
So kind of at a minimum, the carers who are in a group home could have about 6 months of training before they're
But
there.
equally, you need to remember the people that they are supporting may never have needed any physical support with their disability. So if they are now being discharged from hospital or they are palliative and their personal care needs and physical support needs might be increasing, those support workers may have only ever known them in a completely independent capacity.
Yeah, okay, yeah, that makes sense. So then I have a follow-up question for you, Alan. So how does the funding for the group homes work? So if they've got 4 residents, how and one is a palliative care patient, does the funding automatically go up? Or can you tell us more about that?
No, so the funding will only go up once you have done what we call a change of circumstance. So you need to collect all the evidence that you possibly can to show that the person's requirements and support needs have increased. So you need to utilize the multidisciplinary services. So you need to be involving an OT, you need to be involving palliative care teams, you need to be involving medical teams, you need a physio, you need all of the allied health services you can possibly think of, all of the health services you can think of to write letters of support. And if you can get records from the hospitals to show how much nursing intervention has been required whilst they've been in hospital, that is gold standard. Like, that would be amazing. And then you have to present it all to the NDIS and say, this is why we think that this person needs an increase in funding to increase their level of support. And then the NDIS will decide if it is enough evidence or not.
And I can only imagine that process isn't quick, right? Like wow. Okay, so when a patient, say a palliative care patient's in a hospital and they've deteriorated and they're now bedbound, I'm going to ask that question, Penny. The people in the hospital need to do this change of circumstance case to the NDIS, and then Penny's question in the chat there is, how long does that take?
Now that is the gold question, Penny. We have had changes of circumstances that have been in for 6 months, waiting for review. However, that is a very generalized comment. I mean, if somebody is palliative, then you would hope that they would speed up the pace. The hospitals should have access to a slightly faster way of doing it. So they have the home and living teams, and sometimes hospitals will have their own discharge coordination teams, social workers and whatever else that have a much quicker avenue to the NDIS than just NDIS services externally from the hospital. they can expedite those, particularly if you're in a bed blocking situation, because they use that quite a lot of the time to kind of move things along quicker.
And actually, and we're going to come to you, Maria. And A has just added that if a person is already in the community, can a nurse practitioner review them and fill out a change of circumstance form? Do you know the answer to that one, Ellen?
If they have a support coordinator, which a lot of people do, so when you are an NDIS participant, you can engage a support coordinator who will generally do all of that for you. But definitely a community nurse practitioner can write a letter of evidence and support for it and provide it to the support coordinator to submit. But yeah, if somebody does not have a support coordinator and they need to submit a change of circumstance, then yeah, absolutely, you can provide assistance with that. But if the support coordinator is already engaged, then it should go through them, really. Or the hospital, but not as an external, yeah.
So, and Maria, have you got something that you'd like to add to that too? You're off your...
Yes, so there's a NDIS priority palliative care pathway, and there's a particular person who sits within a team that manages this pathway. The pathway is available to new participants, so it's mostly for people that have a newly diagnosed brain tumor and were previously functionally fine and didn't need NDIS support. But I'll put it in the chat when I find it. There is a specific team within the NDIS that you can request support from. And because you're anticipating that a person on a palliative care pathway is progressing with the illness, this particular allied health team will be able to look at the plan and make adjustments to the plan so that there's no, frequent changes required. They can foresee what the trajectory is going to be like for this person's illness and proactively kind of, prescribe allocate funding for equipment or other things. So that's very important. And what I've found recently with a few of my clients, since we've had this person from the NDIA present to us about this pathway and give them the key team to reach out to, the response is coming quicker. The priority palliative care pathway claims a 30-day turnaround. So that's the key thing to it. 30
I feel
days.
like that's an absolute gem, right? That
Yeah.
even just knowing, if we don't get anything, well, we will get so much learning from this webinar, but if we don't get anything else, just knowing about the NDIS priority pathway, that's a win, right? Like,
yes, palliative. So having a palliative diagnosis in the old days used to be a bad thing, where it was very clearly thought that it belonged to health if there was palliative care mentioned, but now it's actually a positive thing in that they are prioritized and the response is far quicker.
okay, thank you. So, and I think this kind of what you were just saying there, Maria, kind of relates to what Amanda Crouch has just said in the chat, which is our experience is that the change of circumstance is never quick, right? So, and I think that sounds like that would be the case, but I guess Maria, you're saying, Maria, that the NDIS priority pathway, they're claiming that it's a 30-day turnaround, so that's good.
Yes. Yeah. And sometimes if it's a simple request, I think one of my family said that they got a response within 15 days.
Right.
So that was amazing. Yeah. I'll put this information in the chat as well.
Yeah, please do. So, and I've got another question. I've got a question for you now, Maria. So I guess one of the challenges, Maria's put something in the chat.
Yeah, sorry.
That was you. One of the challenges I've encountered in homes in a group home with a palliative care patient who has pain are the barriers around pain management and medications and PRNs and opioids. So I guess my question to you is, maybe before we talk about opioids, is what medications can group home staff give and manage? Do you want to talk?
So in general, yes. So in general, people working in group homes can administer anything that's in a Webster pack. So if it's in a blister pack, they can pop out the medications and they can administer it. The important thing to remember, I suppose, is that group homes vary and they have different governance structures as well. I'm not sure whether all of the registered ones have similar structures or not. Ellen might be able to help. But when you worked with one group home, you can't expect that every single group home that you go to will have the same processes and structures in place. It varies significantly across even this one district. We have about 10 key providers that I'm working across. What we find helps is to be able to give the staff in the group home very clear guidelines as to how to respond to different symptoms as the disease is progressing. There's a lot of anxiety, and it's not so much specifically around the management of medications. It's in general the management of symptoms almost in a group home setting. So one of the key things that my role is set out to do is to provide palliative care education to the staff and to be able to talk them through the likely progression of the illness, what the symptoms are going to look like, and what their input is needed to do with that. With the medications, any liquid medications falls outside the regular scope, but there's ways that some of the houses manage that. The time that it becomes very tricky is around PRN medications. And with PRN medications, when we chatted with Ellen the last time, it was around having very clear guidelines around the disability worker being able to make a decision about when to administer it. On the flip side, what I've noticed when I've gone to support a person in an inpatient setting in a acute hospital as well, staff are very reluctant or very, slow at using a PRN medication when the person is nonverbal, unable to explain what the issues are. And the PRNs can be related to pain, but it even can be as something as simple as constipation, which can be the baseline for so much of discomfort for a person. So it's, whether it's in a group home, whether it's in a hospital setting, it's this particular client group, not just the disability workers that need that support. It's the client who's nonverbal that we need to be very clear in our guidelines. At this point, this is what you administer. And this is the time frames within which you should administer it as well.
And what do you think is the best way to do that? Do you think is it written plans? Is it like a folder of symptom management, or is it like in-person education?
It's a combination of both. So what I've been working on is a community intellectual disability palliative care plan for a specific client. So it's a very tailor-made plan. It's got a list of all their specific medications. It's got every single symptom that is likely to unfold as a person deteriorates, and what is the intervention, whether it's medications or whether it's a non-medication type of intervention, particularly around how long to watch and wait. So sometimes, an ambulance or an emergency service is called as soon as there's one vomit, if that person has a bowel obstruction, history of a bowel obstruction, for example, whereas it's like, you don't need to call an ambulance at the first vomit. You can wait and see whether the vomit was related to something else that triggered it. And it's giving the disability workers permission to do that, because they feel the weight of that responsibility on their shoulders otherwise.
And look, and I, as I listen to you speak about that to me sounds very similar to what we would do, the type of education we would do with carers in a home, right? Like a relation carer, like who, the same, you really need to explain everything.
The second most important thing is that it needs to be vetoed by their governance structures. So us going in and saying, we would like you to do X, Y, and Z, it's not enough because they don't feel like they are supported by their provider otherwise. So what I found now is when we draw up the instructions, we get the disability provider to sign off on it and to say we are happy for our workers to do this. Because what we've discovered is that often the first point, or always the first point of contact when things are escalating, will be the disability providers managers. And working with Ellen in Civic was very helpful, because she was able to highlight to me that there's a gap with the training that's being provided. And if we are focusing training on the workers, it's not enough. We need to focus also on the middle management and the senior management as well.
That's another gem, right? Like that. So it's not really, if you've done this great symptom management plan for the carers in the group home, really what needs a step that needs to happen before it's there is approval from their managers, right? Because
Yes.
that's going to be a barrier for them to enact it. That's great. Thank you, Maria.
Yes, yeah, that's really important. And what I found is like Ellen's title is that she's a clinical service manager for Civic. And so the NDIS providers that have a nurse in their workforce who's overseeing the clinical work of this service, it just makes my job so much easier because then I have one go-to person that I can meet and talk to. Otherwise, if you go to different houses owned by the same provider and you're talking to different people that are not at that level, you might get different versions of what can and can't be done as well, which is what I've discovered. So having that one key person that you're able to go to and hear directly from them what can and cannot be done. And then once you know what can't be done, then the discussion is what can we do, what supports are you needed, what education is needed to facilitate and enable that to happen.
Okay. And then I have a question. I think it's quite connected. Is specifically around opioids. So I wondered, Maria, if you could talk to us about how the nurses listening today and they have a patient who has pain and really needs PRN and a PRN opioid. What do you think are the best ways to ensure the patient is going to get that opioid in a group home? And is it possible?
So when the opioid is, in a blister pack, it's prescribed. There's a very clear dose. It's once a day, twice a day, whatever. It's very straightforward. The disability workers are able to administer that. The time that it becomes very complicated is when it's in liquid form and when it's a PRN. I think it's too big an ask for a disability worker to be able to make that judgment about when you administer it, how long you wait before you can administer the next dose. So I find that what they are is their anxiety is so high being an opioid that they are very reluctant to then administer that medication in the first instance. Whereas if it's a PRN in a blister pack, they feel more confident administering it because that's what they've done previously. And they've got a lot of bowel medication, for example, like, if the person's not opened their bowels for 2 days, then you give a suppository, which is not a regular med, it's a PRN, or you give an enema, or you give an extra Coloxil or something like that.
All right. So in other words, no Ordine, like that's really, really difficult. But what about so say, for example, can you have a blister pack that has, endone in it or oxycodone 5 milligrams?
Yes, you can have all that.
Okay.
So we have, so there's been a few homes that have had a workaround for the Ordine type medication.
Okay.
So, and this was vetoed by the NDIS Quality and Safeguards Commission. Because I had concerns around this house taking a bottle of liquid, drawing it up and just administering it with no safeguards that I could see when I visited a home. And basically the process that was set up is that either an RN or an EN needed to be able to oversee the administration of the medication. And because it was going to be physically impossible for the RN or EN to be present at every dose, what was acceptable was a setup of a kind of chat group, something along the lines very similar to WhatsApp. So the person would draw up the liquid medication, take a photograph, send it to the EN or RN, who would then say, it's okay for you to administer this, and then they would administer it. And the Quality and Safeguards Commission said that they were happy with this being done.
All right. So I guess that is a useful bit of information, Maria, just to be to know that is possible. But if we had to have a preference, it'd probably be in the blister pack because it's safer. And I guess, Maria, then I just wanted to ask Alan, can you talk about your service? What do you do in your service when you have a patient who has pain and really needs regular PRNs? What do you guys do?
We are quite lucky in the fact that I have a team of nurses. So all of our SILs have a nurse allocated to that SIL. I mean, they only work Monday to Friday, but they are around. So what we would tend to do is drop a pain management plan, and the nurses would get the information from whichever the treating doctor, nurses, whoever it is that has said they need to have this particular medication, and then they would draw up a pain management plan. We also have a 24-hour on-call service. So they're not always RNs, but it's an escalation point throughout every tier of our organization. So it starts with a team leader level and goes right up to our executive leadership team. And there is somebody available at each level as an on-call. So again, as Maria said, we would have the same thing in place. So if you are administering an S4 or S8 and you are the only person on site, and you're doing it as a PRN, you have to go through the same process. So you still have to take the photograph of it and explain to the on-call why you want to do it, what the plan says, show the plan, and go through all the details. Because we would do psychotropic medications as well. So that's how we get around that.
And I think, so no, go on, Alan. Yeah.
What I was just going to draw on is what Maria had said earlier. So I have got a really good training system for medication for our service, but not all services will allow opioid medications to be administered. So even if it is in a Webster pack, and even if it has been prescribed, and even if there is a plan, some NDIS providers will still have a blanket no to that. It really just depends.
And that's a bit sad,
Yes.
isn't it, really?
Yeah.
But we won't dwell on that, right? At this present moment, right? We could talk about that because we have to talk about that, right? But we won't talk about that right now. Before I move to the next question, I had Fiona Lopa asked a really good question. I might direct it to Maria. What do you do when you've got a patient who is needing subcuts? Subcut PRN opioids, or subcut. Let's start with subcuts.
So what happens is, in general, we work this all out much prior to the person coming to that situation. So there's a lot of communication that's occurred with the house, the management, the senior NDIS, the senior staff in that NDIS service to try and identify what are the limitations of what they will accept in the house. So there was a house where they were happy for a syringe driver to be set up in the house, but it wasn't going to be, there wasn't going to be an option of any breakthroughs being given. So the PRN was going to be, the breakthrough medication was going to be clonazepam drops. So this might not work for all of our clients, depending on the severity of their symptom burden. So it's a little bit hard. Like when I chatted with some of the palliative care specialists about how comfortable they would be about setting up a syringe driver and then tailoring it every 24 hours, a couple of them said we wouldn't be happy with that. But fortunately for this lady, she needed only one breakthrough of a clonazepam drop, and then within a 24-hour period of the subcut infusion commencing, she died.
Okay.
So I sort of, there's a question about deterioration coming up, but it's sort of related in that what we tend to do is when a person reaches the point of needing subcut medications, we identify a location for them to be transferred, mostly an acute facility. We would prefer them to go to a hospice, but we understand that within the catchment where we are, there's very limited hospice beds, and there's no direct, transfers into the hospital unless the bed is identified. So in the plan that we develop, we identify that at this point in time, when subcuts are needed, the person will be transferred.
Okay. Thank you. It's interesting, isn't it? Because it really that's a big barrier, isn't it?
It is.
Yeah.
I feel.
Go on,
Yeah,
Maria.
I feel really strongly that, my group of clients really don't have access to the gold standard of total choice about where they are dying. So this new model of care that we're working on, and we are pulling together all of this information about, whether the person's died in the location of choice, I don't feel like I can answer that question accurately because we are almost limiting their choice in where they can die.
And look, and Amanda has said in the chat, we really want our participants to still have the right to die at home. And look, thank you for saying that. And I think everyone joining agrees. I'm going to come back to that, Amanda, though, because we've got questions later, very, very specific questions about dying in group homes. So I think that's quite related to that. Just before we move on, I'm conscious of time because there's so many interesting things to talk about, but I just wanted to go back. Penny said in the chat there, how do you put PRNs in a blister pack and provide it at different times? And I would, Maria or Alan, could you answer that one, but and you're already doing succinct, but quite succinctly, so that we can go to other questions.
I can do that one if you want, Maria.
Yes.
So PRNs in a blister pack, so they would put the individual tablets in it. So you would have one pack of endone, and it would just have endone. So there's not going to be days and times on it. It's just a blister pack of the endone, and then the pain relief support plan that you have provided would say you give endone if the symptom is present, and then you would go through your own organization's policy procedure for administering opioid medication. So you just keep going. We have the hospital S8 and S4 medication books as well, so all of our staff are taught how to count in and out the medications too.
Okay, cool. Thank you very much, Alan. All right, so I'm going to ask you another question, Alan, to change gear slightly, and I will come back to that question in the chat there, Courtney. Could you talk a little, I have a memory of going to a patient in the community, in a group home, who the plan in the end, she was a palliative care patient, but in the end, the plan, there wasn't a proper advanced care plan. And in the end, that as soon as she deteriorated and she went unconscious, that the plan was to call the ambulance. And I guess my question is around advanced care planning and what needs to be in place for someone to stay in the group home if they're deteriorating. Alan.
Okay. Advanced care planning is up there on my list of things that I just wish would be easier. So I can't talk for every state, so I have access to the New South Wales advanced care planning model. I would still advocate for every single person that we support to have an advanced care plan in place, because at least it gives us an idea of their wishes and their thought process and where they want to die and how they want it to happen. However, there is a section in the New South Wales advanced care plan that says something along the lines of you have to kind of split up your thought process and your beliefs into what you would deem appropriate and what you would not. So what you would want to live with and what you would not want to live with. And then if you had a cardiac event or whatever, you required CPR, it falls onto the person providing that CPR to determine whether or not your beliefs are at play at that point. So if you said, I only want to have CPR if the chances of me surviving, or if there is a chance for me to survive. Now, I can't put that responsibility on a support worker. That's not fair. I wouldn't want to put that responsibility on myself. Now, I can't. How would you, in a situation where it's you and one other person, go and read an advanced care plan, read through all of their yeses and nos, and then you have to make the decision as to whether or not CPR is relevant in this instant? It doesn't work. So we still have, annoyingly, and I don't want it to be, but I have no other choice right now, that even if you have an advanced care plan that says you do not wish to have CPR in whatever situation, we would still have to call an ambulance and somebody in a medical profession make that decision, because we can't do that.
All right. That's
so
that
conversation. Sorry.
No. So I'm just gathering my thoughts. So in other words, is there a form if someone does not want CPR? Is there a simple form that you can fill out to have in a home? There's not. No. And actually, Janet has said here in Victoria, if you have a medical treatment decision maker, you cannot have an advanced care plan. And then Fiona Loper says, and I don't know what that abbreviation means, I'm sorry, MGOC states the client is palliative and not for CPR or intubation, this should be clear and a medication order to follow. Same in South Australia, goals of care, medical goals of care. I'm not even that clear. So you can't, in other words, you can't have not for CPR in a.
There is no document that I've come across yet in New South Wales for somebody with an intellectual disability who is deemed not able to have capacity to make decisions on their healthcare that you can get signed to say that they do not wish to have CPR. So even if they've made it quite clear and that you've kind of had conversations about it, or that the end result or their quality of life would be severely impacted by having CPR. There isn't a document that is clear. So I would love for advanced care planning to be across the board, and it to have a little tick box in it that says, I do not wish to have CPR under any circumstance. However, we do not. And I know that Maria is working on her care plan, which is probably why she wants to.
Well, maybe and Maria,
So,
have you got anything?
yeah.
Because I can imagine this is part of your job, is sending people home who have said really clearly, I don't want to, or their family have said, we don't want them to have CPR. What do you do in
So
this
if the
circumstance?
person has health function and is able to, on the medical recommendation, make a decision that this person is not for CPR, that's what we are including in a care plan that we are drawing up. It's very straightforward when the decision maker is not the public guardian. When the public guardian is involved, it's easy if the person has a very obvious terminal illness, such as cancer or, like a organ failure or something. But when the person has, like very vague sort of functional decline, and you can see them declining, but you haven't put a finger on a diagnosis, it's very hard to get it through the line. But currently what we've done is we've created a plan in which we've clearly stated that this person does not have capacity to make their own decisions. Their decision maker has, on the advice of the medical staff, come to the agreement that this person is not for CPR, not for IV antibiotics. There's quite a few limitations of interventions, no further investigations, and their preference is only for comfort, and the preference is only for comfort measures. So we're drawing up plans. It's currently in homes. So the plan is then signed off by the palliative care specialist, the GP, the decision maker, as well as the disability provider. So the disability workers, I then use that plan as the baseline for the education that I provide to the staff. So the staff can see that we are not just asking them to go outside the scope of their practice, and they feel reassured that it's signed off by their providers as well.
Yeah.
And that's the way around it at the moment. Yeah.
And I think actually that goes back to what we said before, wasn't it? That anything significant like this, really the first step is to get it approved by the facility manager, or even the middle level manager and the medical team as well.
Yes. So the advanced care directive, a person needs capacity to do that. With a plan, there's within the electronic medical records in New South Wales at the moment, there is a place that you can write in a conversation. So it's not necessarily a form that is filled out, but you can say conversation about limits to interventions has been had with a key decision maker, and this is the preference. Even if it's not like a hard and fast rule for New South Wales health staff to follow, it triggers that the conversation must be had before they initiate anything.
Yes. And actually, look, and Maria, Jane has really usefully added there. In my organisation, we need a current palliative care plan and a doctor to have stated that death is imminent and CPR is to be withheld, is the only time that the support workers will withhold CPR. This needs to be signed by the patients, the doctor, the decision maker, as well as the manager. That's a really great summary of it, Jane. So thank you for that insight. And Kieran's also said, from my experience, most of the time the support staff end up calling the ambulance because they are not comfortable with the advanced care plan unless the RN's available on site. And I think that goes back to what Jane and Maria have just been saying, which is that this piece is it's a lot for someone, and Alan said it too, a lot for people to hold, isn't it? So it really needs to be signed off higher up.
Yeah.
Now, is it okay, Alan? I'm going to ask this question it'll be for you and Maria, and it's related. So I'm going to move on to another question. Is that okay, Alan?
Yeah.
Yep. So my question then is, how do you effectively manage deterioration in a group home? And this is the kicker, can people realistically die in a group home? If we're being really honest, is it possible? And I think I had Maria down to ask. Alan says yes, you could both answer it, but we had Maria down, so Maria can answer first.
So in my opinion, a person can die in a group home only if their symptom burden is low and it's being managed with oral medication. So I've had two clients die at home. One was with a syringe driver that, the house was happy to have without the staff providing any breakthroughs. But the second person had a very low symptom burden, had bowel cancer, and just slipped away in the night. Everyone else, they've so far been transferred back into hospital for end of life care.
Okay.
So that's the reality of the situation. I think it makes a lot of people that are very invested in this space quite angry because, I think my role was created very specifically to facilitate end of life care in a home. But realistically, the way the landscape is at the moment, unless there are there's provision for registered nurses to be able to access, to be able to provide support in these houses. Administration of subcut medications and management of these syringe drivers are just not an option for them. I think that, in a group home setting, the way that we manage deterioration is by giving the disability staff very clear guidelines as to, what is expected. So we go through drowsiness because they were, a group home would call an ambulance if the person didn't wake up for the next lot of medication and, just freak out about it. So we give them clear guidelines. You can miss a couple of doses of the medication. You can wait 24 hours if they sleep through 24 hours, and trying to redirect them to observe the person, identify any distress of any kind, whether it's physical distress, whether it's emotional distress, any kind of agitation, anything that in general would cause discomfort. And that being the trigger, rather than looking at their policies, procedures, and just going off what the rule book says, and coming back to looking at the person.
Yeah. So you're saying that it's difficult, but it's
Yes.
possible, right? And I guess
So, yeah.
and Maria, I just want to see what Alan has to say too. Alan,
Yeah.
if you've got something, thank you for that. Alan,
Yeah.
have you got something to add too?
I was just going to say, I think that the mindset needs to be that this is not a blanket no. I think that it is a group effort, and it is hard, and it might take a bit of tweaking, and it might take a bit of staffing changes, and it might take a few steps, but I think that it is certainly possible. And I do realize, that there will be some times where medically, it's just not a safe environment for somebody to be in because we just can't sustain the amount of PRN subcut injections or whatever it might be. But I just think that the answer should be yes until it's a no, is my thought process on it.
Thank you, Alan. And there's been lots of thank you so much for everyone for keeping adding in the chat. I'm just going to read a few, and a couple of the questions that have come in relate to the next few questions. But and this is a great point, A's added that I think even when there is an NFR signed, group home staff should feel able and comfortable allowed to call an ambulance. I totally agree with you, A. I think the mindset that ambulances are only for acute intervention. So in this circumstance, they need to have more support, which the ambulance can give. Yep, I totally agree with you, A. And Amanda has said, we have been able to have people die at home working with our local palliative care team. Good communication and planning with staff, right? That's like the take-home message, I hope. Thank you, Amanda. And Janet has said there's a lot of fear around supporting someone dying at home. And that is my next question, actually. And Aileen, your question we're going to come to in a minute as we finish. So
can I say one quick thing as
Please.
well, Sarah? There's a lot of fear because it's a coroner's. So the more education and support they're provided to be able to anticipate, what to expect, it's better for them. One big lesson that I learned is about the relationship, the trusting relationship that you develop with a house. I think that, initially when I was supporting a person who was dying in a home, it wasn't a group home as such. It was a private home that was fully staffed by disability providers, and the person lived in this house by themselves. So they didn't have any informal supports in place. And basically, because I was asking so many questions, they got very anxious about me visiting. So they kind of shut the doors, and I found it very difficult to go in and support and monitor this person. And, I think the lesson I learned from that, because finally, when it was identified that the person was in their terminal phase, it wasn't it wasn't done as well as it could have been. So the big lesson for me was to develop a trusting relationship, to ensure that the patient is eyeballed on a regular basis, regardless of what the disability workers are telling you, unless you totally trust that what they are, the information passed on. But to have like a time frame, if this person is in an acute phase where they're changing, to go and visit an eyeball and check on them as well.
Okay, thank you, Maria. And I think I just, there was a bit there that you said that was, I think is an important point to make, is that every death in a group home is a coroner's. Is that right?
Yes.
And what comes with that is that right? Is that what comes with that is a police visit as well when they die? Now
It's a police visit.
Yeah.
And recently, one of the clients who died, the one who had the syringe driver running, the home was so traumatized because 6 police responded.
Wow.
And apparently the treatment of the disability support workers was like they were 2 suspects in a murder case.
Wow.
And it was just, so traumatizing for them.
And Maria, this relates to my next question, and I'm just conscious of time, but I think it's important, right? Like, is how do you prepare staff? I'm going to just focus on staff here. How do you prepare staff for a death of a client, and is it important? Like, probably.
So when I did my palliative care training, one of the key things that I found the most helpful of all was a reflective exercise. So I offer that to every single home who's got a person who's dying. I go to the house and, just have a very casual sort of interactive session around what is their biggest fear, what is the worst case scenario, and then we talk through and unpack whatever that fear and anxiety is. And, often we find that the person has had a bad experience in the past, or they are supporting someone at present. And someone who mentioned the fact that you should always be able to call an ambulance. All of the information, all of the training, everything that I provide is basically a guideline. So I say to them, at the end of the day, you're at the bedside, you're the decision maker. You do whatever's best for you in that situation. If you're finding things escalate beyond what you feel you can manage safely, at any time, call an ambulance. There's no right or wrong. It's just a guideline pretty much, and we are here to support you.
Yeah, great. And I think, and just going at that, absolutely. So really, every part of this dying at home, dying in this group home needs to be explained, and they need to be listened to, right? The staff. What I actually was thinking too was that actually, when you're preparing staff for a death at home, do you need to tell them that police are going to come when the person dies? Like,
yes.
It would be very shocking if you didn't know.
Mm-hmm.
Yes. Yeah, especially if 6 respond. And, I have no idea. And apparently there's no process in place. I've recently found out there's a expected death at home form, but it doesn't seem to be for the purposes of someone may die at home. It's only when you're planning a death at home. It's all about who would provide the certification. So I think that the care plan that I pulled together, which has all the advanced care, plans on it, has the diagnosis, all of that information could then be given to the police or whoever responds to this situation as a heads up that this was an expected death.
Yeah. So in other words, if this is happening, if that's the plan, there needs to be really clear, like every step of that, as you would in a home, right?
Yes.
The step of that process needs to be explained.
The additional complexity is that it's a very transient workforce and they work on a roster. So it's covering all of them and, doing it on Teams, maybe recording the session, maybe allowing them to, have it available so they can replay it. That's what I've been doing with a few people, few houses that, where the staff on the night shift can't make it and stuff like that.
That's a great idea. And Janet's also said there may be fear from the staff if someone dies overnight. Absolutely.
Yeah.
It's so sad, right? Because someone has, I think it was Penny said, this is so interesting. Can we have another session? My answer is yes. We could probably talk for another hour, I think, about this topic. We've got one more question, and it's going to be for Alan and for Maria. I'll start with Alan though. What what does a group home need? What does a group home need for a person to die at home? What are the basic, everyone gets their pen down now and writes these things down, what are they going to be writing down? What do they need?
We need a point of communication that is available whenever needed. Look, in an ideal world, it will be a 24/7 service. Granted, that might not be the case, but as close to as possible would be ideal. And to have somebody nominated on both sides that is the point of communication, because look, I don't know about other group home providers, but look, we have 1,000 staff. So, you know, you don't want 1,000 people contacting you if we're shifting around staff on the day and they're constantly wanting to talk to a palliative care team. So you need to identify the points of contact. The other thing is a plan, and as Maria said, the one that she's working on sounds phenomenal. We desperately need that because advanced care planning doesn't work. We can take on board everybody's wishes, but we really need to have the plan in place. And in it needs to be signs and symptoms. It needs to include pain management. It needs to include escalation points. So if you have given this medication and in an hour's time it's not working, what do you do then? Who do you contact? When do you contact them? It absolutely needs to have escalation points. And the other part is, you know, the stakeholder involvement. So it needs to go through every rung of an organization. So I would love to say in full confidence, if you had a conversation with a support worker, that they would know absolutely everything, but they're not going to, and nor would I ever expect them to. So, you know, they might say yes to something, and actually it's not really something that we can say yes to without reviewing policy, procedure, and going through the organizational structure. So those are the main things, and really having an open conversation with the staff about end of life, what is going to happen, what to expect, because we all know breathing is going to change. We all know cognition is going to change. We know that they may decline food and fluid, and you know, this whole, oh, everybody needs to eat and drink to stay strong, and all of that kind of mentality needs to be approached, and we need to have those discussions. And the other point is really knowing who else lives in that group home, because we support majority of our clients as psychosocial supports. So if you have somebody with a mental health illness or has particular paranoias associated with death, then maybe that is not the best environment for them to be in. And it, like I said, it's a yes until it's a no. Some of those no's might be based upon external and environmental factors. So just being really aware of it. My last, equipment. Absolutely. Equipment is really hard to get on the NDI. So if there is a way to expedite equipment through the health system, that is, get us to sign a contract. I would happily sign away on contract saying we will pay $20,000 if we don't return it. I don't care. I just can't get it through the NDIS. So if you can get it through health, that would be better.
Thank you, Alan. And what about Maria? Have you got anything to add to that list?
So one of the biggest gaps we've identified in our district is the access for group homes to after-hours supports. So there is the aged care, what is it called? The quick response team or something, aged care. It's flown out of my head now, I'm sorry. But geriatric flying squad. So, you know, I approached the primary health network who funded the geriatric flying squad, saying we need a disability flying squad for people living in group homes, because it's a general practitioner, an allied health person that can, you know, within a very short period of time, be very responsive, visit the house, check out what's happening, and provide support. I think the 24-hour line that Ellen mentioned is available in the district, but only from medical to medical. So ideally, we would like an after-hours GP service to contact the after-hours, specialist palliative care line to get advice. And it's because if we tell a disability support worker that medications need to change, they can't make any of those changes on their own. So that's a big gap. Within New South Wales, they've got urgent care clinics. I don't know whether it's national. So, you know, we were approaching them about the possibility of providing some outreach to group homes, but that is the biggest gap, the after-hours medical support.
All right. Look, thank you, Maria and Alan. I'm sad to have to bring the conversation to a close for today. But I think probably from all indications in the chat, because there were so many questions in the chat we didn't get to, I think we should have another one. This is just I'm in charge of these things, so I'll just put it in. So look, I'd like to say thank you very much to both of you for this conversation. I hope it's the first of many. And I think the things that have come home to me are there's a couple of pearlers in terms of the terms in terms of NDIS priority pathway. I think the thing that penny dropped for me, that really any plan, if this is what we want to do for our clients, it needs to be approved at a higher level before we're supporting the staff, but then also we need to support the staff in homes in the way that we would support carers and loved ones in a home, and explain everything.
Yeah.
Thank you. Have you got anything final you'd like to say?
Oh, I just wanted to say thank you to Ellen, because, I think health and there's such a disconnect between health and disability. And I was so excited when Ellen said she was willing to co-present with me, and having her input has been what has made this presentation so valuable.
Yes,
it's been
absolutely
brilliant having. I was just so excited that we were addressing it, because it's been hard.
Yeah, well, let's keep going, right? That'd be good.
Thank you.
Have a lovely afternoon, everyone.